Okay, we'll start the
We should start the
IC. Yeah.
session and
So, hello and welcome everybody to our IC on post-cataract surgery endophthalmitis. You know that endoph is one of the most dreaded complications of cataract surgery. So, I'll be talking on the incidence and some basic risk factors for post-cataract surgery endophthalmitis. So incidence is currently declining due to better identification of the risk factors. Now we know a lot of risk factors which can cause post-cataract surgery endophthalmitis. And due to better surgical technique changes, even we require small incisions. We are doing phacoemulsification with 3.2, 2.2 incisions. So that has even caused a reduction in the incidence of endophthalmitis. And also better sterilization protocols, use of horizontal autoclaves, and that has also caused a reduction in the incidence of endophthalmitis. So if you look at the pathogenesis, we know that an insulting agent or an organism, due to its virulence or its capability to cause multiple vascular changes, vasodilatation, increased permeability, and thereby due to the release of their digestive enzymes and toxins, they cause progressive infection with secondary manifestation. So that's what causes endophthalmitis, and it's more in a host with a poor immunity or an immunocompromised host. So if you look at the incidence of endophthalmitis, the global report is 0.02% to 0.26, and acute post-cataract surgery endophthalmitis in India is around 0.04 to 0.15%, and of those who are culture positive is only 0.02 to 0.09%. That's again in India. This is from a South Indian study which covered the like a multicentric study which was done in 2017, which covered all these aspects. So if you look at the organism spectrum, the fungal infection accounted for 2.7 to 70%, and it was mostly from North India, and gram positive infection was 37.6 to 6.4, and gram negative was 24 to 43%. So if you look at the classification, that endoph can be classified into two types. One is exogenous, endogenous, and then on the mode of presentation. So it can be acute, subacute, and chronic. So acute endophthalmitis, the most common organisms are staph, streptococcus, gram-negative bacilli. Subacute is staphylococcus epidermidis, which is normal commensal of the lids. And chronic is by propionibacterium, coagulase, negative bacteria, and even fungal can have a delayed onset of presentation of more than 6 weeks. So again, post-operative endophthalmitis, multiple organisms can cause. Fulminant, that is less than 4 days, that's acute. Gram-negative, most common is Pseudomonas aeruginosa, Streptococcus pneumoniae, and staph. And acute, 5 to 7 days is coagulase negative, staph epidermidis. Fungus can present but extremely rare. For example, Candida. And even chronic or delayed for more than 6 weeks, it's either propionibacterium, fungus, aspergillus, or Candida. So if you look at the microbiology profile, multiple studies have been done on post-cataract surgery endoph, and the most common bacterial species which has been isolated is staph epidermidis, which is a normal commensal of the flora, and the more virulent one is the Pseudomonas aeruginosa. And when you look at the common fungal species, in the North India it's usually aspergillus, and in immunocompromised patients you find mostly Candida species. So what are the risk factors? So it can be classified into three: systemic, local, and intraoperative. Systemic is an immunocompromised patient with diabetes, on steroid therapy, patient with rheumatoid arthritis, or another source of a septic foci in the body. That's mostly the cause of endogenous, but that itself needs to be treated first before you do a cataract surgery, before you perform a cataract surgery, and avoid getting a risk of infection. So local causes can be chronic NLD obstruction. You need to treat the dacrocystitis before you go in. You need to check the rhoplast, blepharitis, canaliculitis. All the ocular surface infections need to be treated first. Conjunctivitis, contact lens needs to be removed and followed by at least for 1 or 2 weeks, followed by cataract surgery. Ocular prosthesis in the other eye needs to be cleaned. The other hand has to be removed before you plan a cataract surgery. And also intraoperative, prolonged operating time, wound dehiscence, touching the iris, a bigger wound, vitreous loss or vitreous coming at the vitreous wick syndrome, retained lens matter, contaminated instruments and solution, all these are risk factors for causing endophthalmitis. And even those who have had traumatic cataract with a penetrating injury, proline IOL haptics, contaminated IOLs and viscoelastics, and also sometimes it depends on what type of surgery you are doing. So the smaller the wound, the lesser the chance of having endophthalmitis. So yeah, these are some of the causes: chronic NLD obstruction, prolapse of iris through the wound, or a non-properly sutured wound, then wound dehiscence or infection of the wound, and also we can proline haptics can also cause proliferation of the organisms onto the IOL and lead to endoph. So there is another entity called cluster endophthalmitis, which is even more dreaded. So its occurrence of endoph much higher than the local incidence pattern, or occurrence of 2 or more cases of infections at a time, or occurrence of repeated post-operative infections under similar circumstances. That is with the same surgeon, same staff, or same operating room. So multiple endophthalmitis incidences happening with the same surgeon in the same OT. So anything more than 2 happening at the same time in a period of a short span of time is termed as a cluster endophthalmitis. And here the sources are a little different. So it could be surgical intraocular instruments due to irrigating fluids, dyes and viscoelastic use, the surgical environment, the air from the OT, and contaminated phacoemulsification machines are the potential sources here. So here the most common isolated and causative organism are gram-negative, and most common one is the Pseudomonas aeruginosa, although other bacteria have been reported. So these are often associated with nosocomial infections, and they are the ones which lead to more of cluster endoph outbreaks, and they're exogenous in origin, that is from outside the body, and sometimes even post anti-VEGF injections can cause cluster endophthalmitis if the whole batch is infected. So Pseudomonas aeruginosa endoph is usually extremely virulent organism and causes dense presentation of the endophthalmitis. As you can see, they lead to more of conjunctival congestion, chemosis, corneal edema, corneal infiltrate, and even on the B scan you can see they present with a dense vitritis with a retinochoroidal steel thickening. So it accounts for approximately actually 1% of the culture positive cases, and the incidence is around 8 to 34% in cluster endophthalmitis. So due to its elastase and exotoxin production, they cause severe intraocular damage and globe distortion. And they are also very difficult to treat because they have multi-drug resistance sometimes, even to fluoroquinolones, aminoglycosides, piptats, ceftazidime. And report over a 10-year period, they cause visual and anatomical outcomes are poor despite the early treatment. So there are multiple reported cluster endophthalmitis in India over a period of from 2003 to 2012. And you can see the most common isolated organism is Pseudomonas aeruginosa, whereas some other organisms like Enterobacter and also Klebsiella have been reported. So this is another study, so where there's a cluster endophthalmitis was reported, and this was with extracapsular cataract extraction as well as phacoemulsification, and they all presented. And here again the most common organism isolated was Pseudomonas aeruginosa. So we have, from Arvind, they had reported even acanthamoeba cluster endophthalmitis, a case of series of 5 patients who after undergoing a routine phacoemulsification cataract surgery presented with corneal ulceration and infiltration with severe pain and chemosis, and all of them had undergone penetrating keratoplasty after the treatment for the acanthamoeba, which was isolated and it was seen on the confocal microscopy. So that brings an end to my talk. I have spoken on the incidence, risk factors, and also the most common organisms as well as the rare ones. Thank you. Discussion later?
Yes. What was the cause of the acanthamoeba cluster endophthalmitis when you went back and saw it?
Yeah, so the cause of was the infected, the improper sterilization from the autoclave. They had a vertical autoclave, and then that was the cause of the cluster. And that was actually, when they referred all these 5 patients, only 4 of them they came to us, and 1 had gone somewhere else. So we, of the confocal microscopy of the floor, all of them was found. They were found to have trophocytes. And when we went back and asked the previous hospital as to what was the cause, they said it was the improper functioning of the vertical autoclave which they had.